Okay, I think we can start. So good morning, good afternoon, good evening to colleagues. This is really great pleasure to welcome you to our next webinar. My name is Jacek Tyszko. I'm the Senior Advisor on Faith Engagement in the UNAIDS Secretariat. Before giving the floor to our today's facilitator, let me just tell you that we will be recording this session and the outcomes will be posted on the Interfaith Health platform, and that you have a choice of language among English, French, and Spanish versions. So on your screen, you will see the icon for interpretation. Please choose the one that you prefer to listen to us today. Let's move immediately to the business. I just tell that this is our one of our webinars in the series of many that are organized within the UNAIDS PEPFAR Faith Initiative and hosted today by the Interfaith Health platform. And it is especially a big pleasure and honor that I can now give the floor to our great friend, Sandy Turman from PEPFAR, who is who kindly agreed to facilitate today's meeting. Sandy is Chief Strategy Officer in the Office of the U.S. Global AIDS Coordinator and Health Diplomacy in the U.S. Department of State. Sandy, the meeting is in your hands. All the best.
Thank you, Jacek, and good morning, good evening, good afternoon to all of you, wherever you are. It's always a treat to join these webinars and to be part of the great work that UNAIDS and PEPFAR and all of our partners are doing together in this space. I want to especially thank Jacek and Francesca and the team at UNAIDS for putting this webinar together today. We've got incredible speakers, and I'm really excited about being part of this. I want to start off just reminding everyone of time. We have great presenters. We want to try to stick to time, so we have some time for dialogue as we go forward. So that's just a reminder. And I want to go over our goals and objectives for the meeting, just to make sure that we are all on the same page as we begin. As you can see here, we want to raise awareness on the issue of migration and health among faith groups. We want to create synergies and opportunities of collaboration between faith and other sectors. We want to offer an overview of migration, situation and challenges, and accessing health services in the context of COVID-19. We want to offer a refresher of the roadmap on HIV among migrants and refugees and the role of faith developed by the FBOs and UNAIDS and PEPFAR initiative. We want to showcase through images the journey and contribution of faith to addressing migration challenges and in accompanying migrants. And we want to present promising practices and lessons learned by faith groups and other sectors in the 4 key areas of the roadmap: in prevention, testing and treatment, addressing sexual and gender-based violence, and addressing stigma and discrimination. So that's a pretty packed agenda, a lot of good work to do, but I'm really excited about that. And I think we ought to go ahead and open our first session today. So let me introduce our first speaker, Dr. Carlos van der Laat, who heads the Migrants and Health Assistance Program at the International Organization for Migration. So Dr. van der Laat, are you ready?
Yes, thank you very much.
Great.
I will be sharing my screen, so just give me a moment and I will share my presentation. I think that you can see it right now.
Yes, we can see it.
Good, perfect. So thank you very much. Whoops, I think I'll start here. I'm sorry. This glitches. So thank you very much. It is really a big pleasure to be part of this interfaith webinar on migration and health, and a big honor also to be part of this opening session. today to discuss about an unprecedented threat from COVID-19, not just for our own health, but also impacting strongly in the health systems, in our jobs, in our families, spreading human suffering, affecting global economy. Also to discuss a very important topic, which is xenophobia, racial discrimination, inequity, and the context of those left behind. So to discuss this topic now, although they have been part of the life of those living with HIV for years, for many years. I want also to start basically to say that we need to remember that for migrant, refugee, and other displaced populations, their situation was challenging before COVID. I mean, now it's even worse in some cases, but yes, it was very challenging before COVID. And the objective of this presentation is to set base in terms of additional challenging contexts that migrants face now with the COVID-19 era, and recognizing that special actions need to be designed and implemented to guarantee inclusion first of all. So, as we all know, the virus appears more or less 15 months ago. Initially, we thought it would be just a challenging time for the health sector, affecting mainly people with pre-existing conditions. We thought that by strengthening health systems, we would be ready to face it, and that those countries with strong health systems were going to beat the virus easily. But no, we began to hear other voices, sometimes too many voices, and we saw that the issue was highly political, revealing in some countries big gaps also with missing or weak public health policies. We also realized the importance of human behavior and personal perceptions towards health. People totally denying the existence of the virus, shouting for freedom or avoiding the use of masks, with all types of strange conspiracy theories, with vaccines that turn us into machines, etc. And then we understood also the link of the disease with socioeconomic conditions, bad sanitation, risky home conditions, etc. Then all the hidden truth came to surface also. All the systemic inequalities, structural barriers based on race or ethnicity, all inequalities were now visible. Even in societies that we consider highly advanced, they came, they were visible now. And finally, the virus revealed the enormous weight of human mobility, for good and for bad. It made us think about borders, which were able to delay arrival in some countries, but were not able to avoid entry of the virus. We realized also the enormous cost of closing borders and the high human cost also associated with confinement. And all this happened in 1 year and made us learn many things. But it seems society also has a strange memory gap. And I'll tell you, none of this is new. This is the repeated story of HIV and how it has affected many lives for many years. HIV started as a health issue, but it was immediately a cause for hate, a reason for displacement, a good excuse for stigma and discrimination. HIV is also strongly related to good or bad public health policies, access to health services, human behavior, and yes, I would say, and I will try to highlight the yes in terms of also it's very related to human mobility, to migration, to displacement. So as you can see, it is a very challenging situation with COVID and HIV. But also regarding all this cycle, it's also a lot of lessons to learn. We have a lot of lessons to learn, and that is the important thing that we need to now use here. So we need to remember also that relation between what happened now during this year with COVID and also what has been happening for long years with the HIV situation. So now we're seeing a reduction in global, regional, and local mobility due to fear or due to travel restrictions. due to lack of confidence also in public health measures, and probably because of stricter health requirements for travel. But with more complex requirements to travel, we'll also probably see an increase of irregular migration. And with it, we will see also more health vulnerabilities. So now with COVID-19, we're learning many things. And now it's not necessarily only about leaving no one behind, as we have been repeating during many years. It is basically that if someone is left behind, no one will move forward. And that is the main clue issue here. If we don't move as a society, we will just don't move forward anymore. And that is, yes, the important message to in terms of integral, in terms of inclusion approach to the whole situation. And now within the health crisis that we're seeing a big impact in terms of high morbidity and mortality for migrant populations. And this is basically due to many specific conditions. Maybe the first one, and I would say that it is the most important one, is the condition is the importance to highlight the fact that migrant populations are not assuming a passive role within the crisis. This is a very important fact. It's interesting to see how society now, because of this virus, is starting to see the essential role played by migrants who are as frontline responders there, and should be recognized as the heroes within this crisis, showing up for work every day to clean, to keep up the food supply, to deliver food to our houses, to give care to the sick as nurses, as physicians, and this needs to be recognized. But unfortunately, also being there means also a much bigger exposure to the virus. Also important to focus again on migration as a determinant of health. Tens of millions of vulnerable people on the move live in cramped, unsanitary quarters where the virus spreads easily. Even the simplest measure as physical distancing or hand washing or the use of masks is just impossible under the difficult context that migrants encounter. So in a camp-like setting and shelters where refugees, migrants, and IDPs could be, the risk of infection increases in 20% just because of the conditions in the environment. Also important to highlight the disruption of health services. We are seeing total eruption of antiretroviral in some countries and critical low stock in some of them. With this, many more people living with HIV, and especially those living with HIV on the move, are and will be affected. And so this is also important to say. Among other challenges, we need to say that the crisis is not just a health crisis, but it is an interlocking crisis with four specific areas. One is the health crisis that I mentioned, and the other one is the socio-economic crisis with unemployment for migrant workers, which leads to irregular migration status. And this affects directly in the communities of origin, in communities where people depend on remittances for food, medicine, education, housing. So suddenly, without income, these groups, these people can no longer afford to stay where they are. We also talk about the protection crisis, and this is basically with restrictions that also impede humanitarian workers to provide their life-saving services. With closed borders, states closed also all entries for people seeking protection, and those who are already in refugee camps or organized as asylum seekers are now encountering fear, hunger, stigma, discrimination, and big uncertainty also regarding their situation. And finally, one fourth crisis that I would say that is also very important to consider, and is this perception crisis. When we start thinking only in our security, when caring about the others seems not to be as important as it should be, and when governments apply restrictive sanitary measures based on xenophobia or persistent inequalities. So as WHO, as the Director General said, our greatest enemy right now is not the virus itself, but fear, rumor, and stigma. And the same happens with HIV. So this is important to see. Stigma prompts social isolation of groups and a fear of seeking medical attention, which in turn, it also can undermine the effective inclusion of migrants in public health information efforts. We're also learning from this experience that we'll get through this crisis, but the only way to do it is if we work together, in solidarity. We always say that the world is as strong as the weakest health system, and we need also to highlight this regarding this big crisis that we are living. And this applies for COVID and has applied also for HIV for a long time now, affecting the lives of many people and families. So stigma and discrimination is an important topic that we need to strengthen and discuss and talk a lot. So the panorama is quite challenging. I'm just sharing some pictures of the current scenario where it's clear that it's much more than just a health sanitary crisis. With or without COVID, people continue, to flee violence. Conflicts are still there. We maybe during this year we said, oh no, things are better. No, conflicts are still there. War, violence, all that is there, but protection is suspended now. We can see how fear and not counting with information is also creating vulnerability. So me as a migrant, prefer not to be tested to avoid higher discrimination against me. The fear of being locked up in a not secured in a space for COVID. The anti-migrant violence, not allowing food or medical care to be provided. People very scared, or the fear from stigma, with just one big outcome, that is basically higher exposure to the virus. And finally, the fear of living in places without sanitary conditions, without water, with no possible distancing. Just imagine for these people in this picture, what it means when we say keep your distance, wash your hands, use alcohol inhale, change your mask. I mean, it's just impossible within their context. So from IOM, we reiterate the need for migrant inclusive approaches in the overall COVID-19 response. We need to highlight the importance of addressing the particular needs and vulnerabilities of migrants, regardless of their legal status. All of this in the spirit of the universal health coverage. Now there is an increased need to bolster also public health services in low income and humanitarian settings. That is probably could be one of the most important learnings from COVID, that we need to really strengthen the access to health in this very difficult settings. And also, we know that the best people to engage communities are those who have existing trusted relationship with people in the community. We also know that community trust is vital to every effort that we can do. And we know that the fight against COVID-19 cannot be won unless the response plans in all countries include migrants, especially those marginalized or in situations of vulnerability. And this is why this is very important for me today, because it is only possible with the proactive participation of the faith-based organizations. Those of you who are already in the communities, those of you who are already who already count with trust and have an open dialogue with community leaders. Those of you who are experts in community engagement, it is only possible through humanity, hope, love, and acceptance. These 4 words that I took from the roadmap. So basically, I think that the roadmap is there, and we just need now to adapt it to work even more in terms of COVID response and in terms of HIV. And so I'll leave it here, insisting that these populations need specific measures and strategies of community engagement. And yes, also repeating again and again that public health only works when everyone is included. There's no public health without inclusion. So thank you very much. And hope to answer some questions later on. Thanks.
Thank you, Dr. Vanderlot. That was very provoking and thought-provoking. So we greatly appreciate your thoughts, and that was wonderful, wonderful presentation. We look forward to being able to ask questions shortly. Thanks. And so now I have the great pleasure of introducing Father Rick Bauer, who's the Director of Spiritual and Psychosocial Care at the Eastern Deanery AIDS Relief Program in Kenya. Father Rick, are you there?
I am here. Great. Thank you so much. And good to see you, Sandy. I wait for that face-to-face meeting, hopefully soon.
Soon. We're all hoping and praying. Thank you.
So again, to the organizers, thank you so much for the opportunity to share, kind of maybe shift gears a little bit to look at the response of faith and theology to what Dr. Vanderlot just mentioned of this unprecedented crisis. Next slide. So theology provides us with a language to understand the nature of God or the divine, our beliefs, and how this knowledge of theology and our experiences can impact our lives and relationships. Clearly, migration, the movements of people across borders, within borders, in IDPs, is unprecedented. And some are even calling this the age of migration. So I believe that we need to examine both a theology of migration as well as spiritual and pastoral care of migrants. These two are related, but they're distinct. Theology gives us questions. And so I begin with, more questions for you, in light of this age of migration. How can our sacred texts help us to understand the signs of the times? How do we understand God through the eyes of migrants? And as people of faith, how do we understand migrants through the eyes of God? Next slide. So almost every of the major world religions has this golden rule. Do unto others as you want people to do unto you, or don't do to people what is harmful for you. Next slide. And yet, despite this universal ethical spiritual guidance across world religions, when we gather to better understand migration and migrants, we often only focus on economics and politics and geography, sociology, psychology, law, history, anthropology, and now environmental studies, and other academic disciplines, but theology is almost seldom mentioned. And so that's what I want to provoke a little bit today. Next slide. So I would propose that the academic discipline of theology offers not just more information, but a new imagination, one that helps us as healthcare workers, as people of faith, to reflect on what does it mean to be fully alive, fully human before God, and what does it mean to live together in community with harmony, dignity, mutual respect. Again, as Dr. Vanderlot said, if anyone is left behind in HIV or COVID, we're all left behind. Now, Daniel Grudy, my colleague, is one of the few theologians reflecting on a theology of migration. And he speaks of three theological themes from my own tradition, my Christian tradition, that help us understand our response to migration. And I know my Muslim brothers are going to talk about some of their theology and best practices later. But Daniel Grudy talks about these three theological concepts or themes: the image of God, the word of God, and the mission of God. Next slide. So we begin with the image of God. And for many world religions, for the people of the book, Genesis offers us a truth that we are all created in the image and likeness of God. This is central to our understanding of the innate dignity and the worth of every human being, divine attributes that are part of every human life. And yet, for so many migrants, the common denominator of their experience is dehumanization. And so our theology can help shape a worldview to understand this dignity of every person. The concept of innate human dignity helped to shape the Universal Declaration on Human Rights and the United Nations Convention on the Status of Refugees. And I think this innate dignity of every person, we as people of faith need to bring forth to shape our discussions and our action plans. Next slide. So the Word of God. Now, this is from my own Christian tradition. I share theologian Daniel Grudy's belief that a theology of migration reflects on the incarnation of Jesus, the belief that God migrated to humanity so that we can migrate back to God. And this theology proposes that the very nature of God is migration or movement. Almost all of the world religions and even the non-religious spiritual traditions often speak of a spiritual journey, movement, migration. And so in the Christian tradition, the word migrated to become one of us, to bring God's healing love to a broken world. The word migrates to the earth to reconcile us to the Creator and each other through a renewed humanity and a new creation. Because God will always cross over all the divisions that we human beings create to help us find a right relationship with God and each other. And as we develop and increase our understanding of migrants and migration, I believe we'll also grow in our understandings of God and vice versa. And third and final is the mission of God. And this theological concept articulates the action, the movement, or the mission of God. Pope Paul VI said that our mission of the church is to proclaim a God of life, to make our world more human by building up a civilization of love. And so the mission, the work, the movement of God is to restore that image of God, that dignity to every person through the redemption of the Word of God. Now, a central dimension of Jesus' life and ministry is reconciliation. Again, overcoming those human constructions that divide us. And so by word and action, Jesus demonstrated that welcome, compassion, mercy that requires us to give primary consideration to meeting the basic human needs of migrants, including healthcare. And so we move from a theology of migration to pastoral and spiritual care of migration. That a theology of migration helps us understand the dignity, compassion, and that ethos of welcome. We have to end the division of us and them and acknowledge that there is only us. In our care for all of our patients, I believe, but especially migrants, we need to adopt a true biopsychosocial spiritual model of assessment and care, and knowledge and acknowledge that every person has spiritual needs that may be different from my own, but need to be addressed and supported in the healthcare system. God migrates into a world that is broken and divided, not because God finds something good in this estrangement, but because precisely in this place, God can reveal hope through ourselves to anyone who is experiencing rejection and alienation. And so how do we put this into practice? Well, at EDARP, people that know me know our 3 rules of all of my staff members. Spend time with God, however you understand that concept or word. Take care of each other, take care of the patients, and never change that order. We have over 30,000 HIV positive adults and children at EDARP, and at any given time, about 500 to 900 migrants and refugees. And like all of our patients, they too have about a 93% viral load suppression. And I think it's due to this ethos of welcome, or in Swahili, karibu. Karibu, karibu, karibu is the ethos of our clinics, that all are welcome, wherever you're from, or however you may have been infected, or whether you have COVID or HIV or TB, everyone is welcome. And then there is comprehensive, and PEPFAR calls this differentiated treatment, but I think as people of faith, we've got to articulate a biopsychosocial spiritual model of health, that everyone has spiritual needs, and how are we addressing those? That the dignity of every person that comes through our clinic doors. Next slide. And so, if it's not theology, it's also art. And art, this is a beautiful sculpture that was influenced by Hebrews. Do not neglect hospitality to strangers, migrants. For by this some have entertained angels without knowing it. And you can see in this sculpture that's at the Vatican, and it's also moving around the world, a history of different migrants from different countries, and in the midst you can see the angel wings. Next slide. And so my final thoughts is we need more reflection and writing from our theologians and for those of you that are teachers, our students of theology, on a theology of migration to add wisdom, deeper understanding, and a more compassionate response. Theology helps us to articulate God's love, God's compassion, and mercy, and they inhabit every place and space and knows the pain of betrayal and misunderstanding. Theology contributes to our understanding and experience of a reconciling love and mercy that helps us to welcome the stranger as our neighbor, as our brother or sister. Our sacred texts compel us to a more humane and a more ethical response where every human person is treated and cared for with dignity and respect. And finally, our theology can improve our understandings and of a comprehensive care and treatment for HIV and COVID, creating not only healthcare systems, but creating caring systems of health. And next slide, Asante.
Asante Sana, Father Rick, that was an excellent presentation and a powerful sermon. So we are all grateful for that. And I have to say, I look forward to investigating and having a conversation with you about Daniel Grudy's work. That's very, very interesting. So thank you so much. And I look forward to our having a chance to reach out to you again in a few minutes for some questions and dialogue. So I think at this point, Francesca, if I'm not mistaken, we're going to go ahead and move into our next session, session 2 of the presentation today. And our first speaker in this next session is Reverend Paul Jeffrey, who's a Methodist minister and a photographer. Jeffrey, are you there? Paul Jeffrey, are you there?
I am here.
Oh, great. Okay, then take it away.
But more importantly, the video is here.
We like that. That's even better.
Since conflict and hunger first drove people to leave home in search of survival and refuge, others have welcomed them, healing their wounds and providing a safe space for life. Such hospitality has often been driven by faith, and around the world today, people of faith are often found at the forefront of those providing safe shelter and health care for some 80 million refugees, displaced, and stateless people. When Venezuelans flee political turmoil at home, Brazilian church workers offer food and accompaniment. When Yazidis fled ISIS troops in northern Iraq, they found people of faith ready to heal and support them. In Austria, when young Afghan asylum seekers needed to learn the language, they found church volunteers ready to help.
Okay, jemand anderer? Diese gelben Dinger, das sind Kichererbsen. You know Erbsen? Pea, the green ones, yeah? Peas. Pea, yeah. Die grünen. But das sind Kichererbsen. Weißt du, was Kicher ist? Kicher ist. Das ist Kicher.
In Uganda, when South Sudanese families sought safety, they found volunteers, often motivated by faith, ready to help sustain life.
Is it painful? Not painful. Okay.
Sorry.
In Hungary, when a flood of refugees provoked a harsh government response, faith-based organizations stepped up to provide food and drink, safe places for children, and a general sense of welcome. In Bangladesh, where persecuted Rohingya fled for safety, people of many faiths responded with love, ensuring that almost 1 million stateless people could survive. When Afghan refugees fled for safety to Pakistan, they found doctors from the Islamic Relief Society there to care for them. Inside South Sudan, more than 2 million people have been displaced by horrific fighting, and they're often forced into the bush where they survive on wild leaves. While some have sought safety on United Nations bases, tens of thousands of others believe that the church offers literal salvation and have sought shelter in church compounds, sleeping in the open, trusting the church can be an island of peace in a veritable ocean of war. At great risk, church workers accompany the displaced, providing everything from education in the camps to the disposal of unexploded ordnance in farmers' fields, to accompanying women returned from exile as they reestablished their farm fields. In the United States, the destination of many who flee repression and climate-fueled poverty in Central America, people of faith wander into the desert to provide water for thirsty migrants. While on the Mexican side of the border, faith groups organize food for hungry asylum seekers. For those who make it across the border, faith-based groups offer employment assistance, housing, and orientation about everything from how to use a bank card, to how to ride a bike, to how to use the phone in an emergency.
What is happening?
What is happening? My kitchen is on fire.
Is there anyone in the house?
No, when and
Outside.
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 Okay.
Not in the house.
Okay.
What is your phone number?
0201234567.
We'll be there. We're coming.
To how to take a test to get your driver's license.
Kwa anaenda kwa spidi, kuna wakati anahitaji kwenda polepole, yeye anakuja hapa sasa.
Faith communities are also at the forefront of pushing for humane immigration policies in the United States, at times even providing sanctuary for threatened migrants. When all else fails and migrants are deported back to Central America, church workers are waiting to receive the flights at the airport and offer what help they can to the deportees. And for those migrants who disappeared during their journey north, faith groups in Mexico offer practical solidarity to the many mothers from Central America who search for their disappeared loved ones. In South Africa, when refugees from Zimbabwe suffered xenophobic attacks, it was a faith community that opened its doors to offer medical care and shelter from the violence outside. In occupied Palestine, where refugees lingered decades after being displaced, faith groups provide critical health care, vocational training, and other services, including helping children in Gaza to cope with the trauma of war, though it would appear that the best way to help children get over war is to scare them with something else. One often overlooked face in the collage of global migration is the overseas worker. There can be a thin line between being forced by conflict to leave home and being compelled by hunger to seek work abroad. The Philippines, for example, stays afloat economically on the labor of the workers it exports, leaving broken families behind. Faith-based groups support these overseas workers as they organize in places like Hong Kong, and back in the Philippines, helps those who are survivors of trafficking to put their lives back together. Whether refugees from Somalia who have escaped to Kenya, or Congolese displaced by armed conflict in their own country, or Colombians driven from their home by drug-fueled violence, or Sri Lankans fleeing war driven by religious and ethnic identity politics, or people in the Nuba Mountains of Sudan displaced by aerial bombing, members of faith-based groups are present around the world, sharing love in the middle of despair, risking their lives to bring healing and hope.
That was incredible. And that is such a wonderful way to, I think, frame the rest of our conversation today. So we want to thank you so much for that. So let me go ahead and introduce Gary Jones, who's the Senior Advisor for Security, Humanitarian, and Fragile States at UNAIDS. Gary, are you there?
I certainly am. Thank you very much. Good day, everyone.
Okay.
Right. Thank you. I'm going to go at a whirlwind pace and just outline the roadmap. This is an absolutely critical document of which much of today's debate and participation depends. We can start by saying that it was developed by 70 individuals from 40 organizations, including faith-based organizations and governments and UN agencies, civil society and migrants living with HIV, representing 36 countries. This all happened at the World Council of Churches in February 2019. And it was all about strengthening the HIV continuum for care for both migrants and refugees. Right, the roadmap it's based on real-time experience, and this is one of the key facets. This is personal and community experiences. And we created the roadmap through open discourse between the partners on overcoming stigma and discrimination, improving access to prevention, testing, treatment, and care, and promoting, above all, the human rights of people on the move, migrants within the migration context, and to build bridges among faith-based groups and other sectors to better tackle some of the migration challenges. The roadmap notes, most importantly, that partnership with migrants and refugees is the building block that congregations play a special role in encouraging testing, equipping youth leaders and caregivers to engage in the ongoing dialogue, and to help combine spiritual and care messages. For example, pray and take your medicine. Now, it's no easy path. It never has been. The major challenge concerns, first of all, the lack of data and the need for evidence to drive programs and action and lay the foundations for effective advocacy to improve health and HIV outcomes for all classification of migrants and stateless persons, regardless of their political status. Now, the roadmap provides a way forward in 4 key areas: HIV prevention, testing, treatment, care and support, violence and HIV, and eliminating stigma and discrimination. Each of the 4 pillars taken together point to the imperative of a rights-based, it's okay, rights-based and inclusive approach that is holistic and aims to safeguard health, spirituality, and well-being for all migrants with real-time action. Right, and as for the roadmap, the areas of interventions were organized around this discussion on what we need to know, what is preventing access to services, and what needs to happen to correct this situation and improve health overall, and HIV in particular, for migrants and refugees. The problems is vast, multi-layered, and dependent on context regarding the journey of the migrant. Yet, through careful consideration, participants were able to spot the commonalities, find the synergies, and propose real steps forward relevant to all people on the move globally. Now, it will be helpful to hear during this discourse from participants at this webinar to see how far these recommendations have been actualized, how they've been implemented, and with what effect, with what result, so as to help better our aim with planning and follow-up action. And that's it. And I'd like to say thank you very much. And please, the roadmap was such an enriching experience, and it's such an amazing document that I didn't do it justice. But please put in the chat box any questions, comments whatsoever, and I and the team will do our best to respond. Thank you very much.
Thank you, Gary. That was really wonderful. I appreciate your comments, and I think, and I appreciate your brevity. Now we might be able to fit in a couple of questions. And so, Francesca, have you collected questions, or shall we choose some randomly from our comments?
Thank you, Sandy. I think we can just open up for a few minutes to people. There were 2 comments. One referred to the situation in Myanmar and the other the situation in Ukraine. Maybe the 2 people, the 2 participants. So it's Ronald, if you wanna just open your mic and intervene. And then there was another speaker from Ukraine who also raised a question. Thank you.
Thanks, Francesca.
Thank you, Francesca. Thank you, Sandy. Yeah, it's a bit of a concern. We all know the political situation in Myanmar right now, and we are facing, especially for the border countries like Thailand and India, the migrants, the illegal migrants who have fled from Myanmar, who needs access to treatment in this current situation. How can faith organizations or faith-based bodies play a role in those kind of situation? If we look at it in both the countries, predominantly the treatment is provided by the government. And the government, in some places, the government are not willing to identify the migrants in this situation because of various reasons. We all know that, because of the political situation. So how can we, I think for me, it's like, how can we practically look into what we as faith organizations do or have a role in this kind of a situation? Because their identity has to be anonymous. Otherwise, we have already had threats both in India and Thailand about them to be returned to the country. So I know it's a difficult situation. I know it's a difficult question, but if anyone could give some highlights towards that. Thank you.
Thanks so much, Ronald. Presenters, does anyone want to respond to that, please?
I mean, I'm not in Myanmar, and so I can't, do specific, but I just remember that beautiful picture of that nun standing in front of the guns of the military. And I think one of the roles of faith is to stand up and speak truth to power. And that often comes with huge consequences, but it is our prophetic, stance that, when people are being denied healthcare for COVID, for HIV, we have to stand up and speak truth to power and accept those consequences.
Thank you, Father Rick. Others, do others have comments?
Yes, Madam Chair.
Yes.
My name is Professor Mohammed Karama. I would like to make an input here in relation to Islamic theology as far as migrants are concerned. First of all, migration is encouraged where the dignity of the human person is affected, where the rights are affected. The Quran recommends, and this I like what Father Rick has said, that it is the responsibility of the recipient community to take care of the migrants at any cost. And God gives a lot of blessings for those who take care of the traveler and the migrants. And therefore, theologically, it is important, whether it is whatever faith, whatever person that comes, if the person is a migrant, as faith community, I think from both theological, Christian, Muslim, or Hindu, it is our responsibility to stand with the migrant community. Thank you very much.
Thank you, Professor Karama. I really appreciate that. Are there other questions? Let's take one more question before we move to our next session, if we have one, or comment.
There is just a comment from me. Hello, everyone. Hello from Ukraine. There is immigration to Ukraine, but on the east of Ukraine, there is aggression of Russian Federation. Factually, it is a war. And we have 1.5 million IDPs because of war events in the east of the country. Those regions before the war was on a higher level of disease, Donetsk and Lugansk regions. Many patients are staying without medications, good health care. The migration is a difficult process, and with COVID, it become even greater problem. Religious organizations help HIV service organization. They work together in the collaboration. At the front line, communication is made by the religious organizations because they get asked for help. Yeah, that's just a comment from me about Ukraine.
Thank you so much. It's very interesting. I appreciate your sharing that. So I think, I know we're going to have a little time for some input at the end. So I think to keep us on time to make sure we get all of our presentations in, let's go ahead and start our next session on best practices, if that's all right with everyone. And I want to start by introducing Ms. Alina Smith, who's the Senior Advocacy Officer for Health, Justice, and Legal Strategies platform for the International Corporation on Undocumented Migrants. Alina, are you there?
Yes, hello, I'm here.
Oh,
Hope
great.
you can
Nice
hear and see me
to
all
meet you.
right.
Thank you.
Thank you so much. Thank you for the introduction and really a sincere thank you for the opportunity to join you today. It's already been so inspiring to hear the intervention so far. I work for an organization called PICAM, and our focus is the rights of undocumented people. And it's wonderful to hear, to be in a context where the starting point is not immediately to move to policy, but really to begin the conversation with values. And so I think that's very, very important. And that's already an important contribution of faith-based organizations, is that that's really the point of departure and not something that's brought in along the way. Next slide, please. So where I wanted to begin, actually, again, I'll be bringing a little bit of a European context. PICAM is an international network of organizations, but our main focus is in the European context. And I wanted to begin briefly with just what the pandemic has meant for undocumented people here in Europe. And actually, we heard very helpfully about this from Dr. van der Laat a moment ago. So I'll be able to move a little bit more quickly through my presentation, just part of my presentation. But just to kind of put things in context. Next slide, please. And I know we often speak about migrants as people on the move, but I think it's important to recognize that when we're speaking of undocumented people, very often these are people actually living right here. They're really our neighbors, they're people who in many instances have been living for a long time in a particular place. And they're often working. They may be raising families. And so what have we seen in the context of COVID? As we already heard, much of what we've seen with COVID is a making worse of a pre-existing situation. And we know that for the most part, people with irregular status or undocumented people already had limited access to decent work, decent wages, and as a consequence, living often in precarious situations, poor living conditions. We know that during the pandemic, that many, as we've already heard, struggle to follow the measures to protect themselves because of the way in which they live, whether it's in informal settlements, some of them even in immigration detention, sleeping rough, and so on and so forth. Many, as we've already heard, had to continue working and often doing critical work in sectors where they often have very, very few protections. And at the same time, facing, as we already heard, the prospect of destitution if they have to stop working, either because of sickness or because of prevailing confinement measures. And so it also shows up the gaps in our income protection and our social protection systems, which has an impact, of course, on this public health crisis. Next slide, please. So what is the prevailing context in terms of undocumented people's access to healthcare and other services in Europe? So we already know that if we even just look at the EU, it's extremely differentiated from one country to another. And even within a given country, it can be different in terms of one region to another. But by and large, if you're an undocumented person, in most parts of Europe, you have extremely limited access to primary healthcare. And so this is the existing context. And I think it's important to note that if you have lack of access to primary healthcare, if you don't have a general practitioner, then at the same time, you're not going to necessarily have access to health information, which is extremely important in the context of a pandemic. We know that there are some countries in Europe, such as France and Belgium and Spain and Italy, among a few others, where there are schemes in place to make it possible for undocumented people to access healthcare. But there are additional factors that make it hard for them to do so in practice, often complex procedures and a lot of bureaucracy. And overarching all of this is a pervasive fear of the authorities because of the criminalization of irregular status. And so this means that there's a constant concern about the possibility that accessing services will make them visible to the authorities and actually trigger a deportation proceeding. And so this also means that people might be fearful of even circulating in their neighborhoods because of identity checks and confinement measures that mean that law enforcement may be more present. Next slide, please. And so all of this has a very, very significant impact on risk of infection, but also health-seeking behavior and ability to access access care if they need it. The good news is that a number of international bodies have urged inclusive vaccine deployment. The World Health Organization, we've already heard from IOM, two special rapporteurs on the right to health on the one hand and on the rights of migrants have called for equitable access to healthcare, to the vaccine in particular, for migrants regardless of status, as a matter of human rights. And I've also included here recent recommendations from the Council of Europe calling for equitable distribution of COVID-19 vaccines as a matter of ethics and bioethics. Next slide, please. But what does the picture in Europe look like in practice? This has been really, really challenging to monitor. But through our network and through monitoring the media, PCOM has been really trying to get a picture of how things are looking in practice. We've been working on this map for the last few weeks to try to give a picture, quite literally, of the intentions that states have indicated they have in terms of whether their vaccine rollout strategies will be inclusive in undocumented people or not. And you can see that there are already a number of countries in Europe that have explicitly said they intend, or implicitly in some cases, intend to include undocumented people in their vaccine rollouts. Poland is the one in black, and we know that Poland, the undocumented people are explicitly excluded from their national vaccine program. Next slide, please. So I wanted to just briefly give some snapshots of the national level practice. And also just to reiterate that the approach on the COVID-19 vaccine is one thing, but we need to bear in mind the background context. So the United Kingdom is the furthest ahead in the European context in terms of its deployment of the COVID-19 vaccine. And the good news is that from quite early on in the deployment, the government has been very clear that undocumented people can and should access the vaccine. All it requires is registering with a general practitioner, which is possible for undocumented people. But what we see and what we hear from our members there is that in reality, there are important bottlenecks because undocumented people don't trust the authorities, because there's a long history of what's called the hostile environment in the United Kingdom, which has essentially meant that undocumented people have been discouraged from accessing services, and that there is a line of communication between the immigration service and the national health system. And so this broader context we've seen has actually undermined quite an inclusive approach in the United Kingdom context. Next slide, please. I briefly wanted to give you the example of Ireland, which has taken also a very proactive approach. Ireland's Minister of Health has clearly stated that undocumented people are included in the vaccine strategy. They've taken specific measures to ensure that they can access the vaccine. And importantly, they've made it very, very clear in public statements that undocumented people will not face any immigration consequences if they come forward to be vaccinated. Next slide, please. In the Belgian context, the National Action Plan is inclusive, but not explicit. And efforts have been made to ease access to healthcare more generally, and to put in place inclusive testing strategies. In the Brussels capital region, there is an explicit inclusion of undocumented people. And there are a number of steps that have been taken to really get out in front of this, including working very closely with frontline organizations like Médecins Sans Frontières, Médecins du Monde, intercultural mediators to really develop and devise protocols to reach populations, including undocumented people, people living in homelessness, and others who face particular challenges in the context of the pandemic and access to the vaccine. Next slide, please. I wanted to end with an example from Norway, where actually one of our members has been very active in advocating on this issue. Norway, the context there is that undocumented people have very, very restricted access to healthcare in general. They don't have to pay, however, for care related to infections, but it's unclear to what extent this includes COVID-related treatment and vaccination. At the same time, there is promise because there is active work being done by the Oslo Health Center for Undocumented Migrants, which is an initiative of the Red Cross and the Church City Mission in the city of Oslo, that has not only been running a clinic for a number of years now, providing direct services and assistance to undocumented people, but has has been advocating through coalitions of actors in Norway and working with politicians to really push for more inclusive access to healthcare in Norway, and also working with the media to raise attention for this issue. Next slide, please. We had a call with our members earlier this year to discuss how things were going at the national level, and a number of challenges were noted, but I just wanted to end with some of the practices that were already emerging as promising. And the first was clarity in the intentions of governments, in the instructions of governments and health authorities about how to ensure undocumented people can access COVID-related care. The second was clear commitments that personal data will not be shared as a way of really promoting confidence and trust in the authorities. And third is really to make the processes to access the vaccine as simple as possible with limited requirements for documentation. And next is that NGOs be proactively and actively engaged with authorities in defining the strategies that are used to actually reach people in practice, and in some cases in actually supporting their delivery. And of course, bearing in mind the need for multilingual communication and outreach campaigns to inform people of their rights and of how they can activate those rights. Last slide, please. And these are just 3 quick takeaways to end today. I think, again, the pandemic has made more visible inequalities that many of us have been advocating about for a very, very long time. And I think in our case, we've also seen that, we've seen what governments are actually capable of doing, the policies that they're capable of passing when there is sufficient need. We do see promising examples of what's possible when really push comes to shove, and that should give us hope. Second of all, ensuring access to the vaccine is really important as a matter of fairness, public health, and morality. But it's more than that. It's not a one-off effort. It's really an opening to push for more systemic improvements in access to healthcare and social protection systems going forward. And finally, the pandemic, we've heard from our members and we've seen that it's underlined the importance of intersectoral collaboration and partnerships between authorities and community-based organizations, including faith-based organizations that can help to guide those efforts and ensure that everyone is included. So I'll leave it there for now and look forward to your questions at the end. Thank you very much.
Thank you, Elena. That was really a wonderful sort of outline of challenges and opportunities and wonderful examples of how we can respond and the opportunities for change in the midst of COVID. So I'm really grateful for that. Thank you so much. Now I want to introduce Professor Mohammed Karama from Islamic Relief. Professor, are you there?
Yes.
Thank you. Go ahead.
Thank you very much. I would like to start my presentation by acknowledging my other presenters who really have opened up. And I want to start with just reiterating the issue of migrant communities according to the theological aspect, that it is not permissible for any human being to accept a life that is without dignity wherever they live, where they don't get the rights like health and so on. Islam encourages migration for whatever reason, and that it is a theological commandment that we should take care of refugees and migrant communities wherever they are. And God gives a lot of promise for betterment of life for those who handle migrants and help people find their way in their lives through travel, through migration, and so on, whether in transition or in new settlements. And therefore, I want to really share with my colleagues who have iterated that point clearly. Next, please. Next slide. This is Kenya. As we see, these are areas where Islamic Relief operates. The marks that we're seeing in blue, these are areas, and we can see also the border. Next slide, please. I want to show the relationship between us and Somalia. As you can see, the line across the two countries, it's hundreds of miles, and there is quite a lot of movement between the countries and especially during conflict and when there are conflicts in the other side, sporadic wars that occur, there is migrant communities that travel to the side. And then there is also nomadic movement between the two countries. And therefore migration patterns are not very permanent, but people move from one side to the other. Also, people move in search for better health. Many people move from Somali side to come to Kenya for health, especially in this time of COVID. Next slide, please. Now, understanding stigma from the perspective of HIV and any other disease, because even now we realize that there is a lot of stigmatization, there is a lot of denial for even COVID-19. Stigma can be divided in, these are the unfavorable attitudes or beliefs that are targeted towards people who have certain condition. Either it could be HIV or it could be AIDS. Then there is also self-stigmatization. This is where the spiritual strength comes in. Nobody should stigmatize themselves for whatever status they are in. Then there is the external stigma by people, but other than the person who is suffering from the condition. For example, actions or attitudes which are directed by people who are external to the person who is suffering the particular condition. That is external stigma. There's also stigma associated stigma. You know, there are people who are infected and there are people who are affected. Stigmatizing the affected will also be considered as associated stigma. And then there is institutionalized. In the early stages of HIV, even some prayer places were actually institutionalized stigma, where if somebody showed some signs of AIDS or something, will maybe be rejected or something like that. So we need to address stigma from all perspectives. Next, please. Understanding the gender-based violence, I think and this even was made worse during the lockdown in the COVID situation. We found people, young children becoming pregnant. Several cases of pregnancies were reported, unwanted pregnancies, unprepared pregnancies. Domestic violence was increasing, and this was as a result of the lockdowns that were there. There's a lot of learning that we are learning in relation to gender-based violence that is occurring in the society. And it's not any particular society, it's both religious, Muslims, non-Muslims, and all others. And I think it's a big challenge that we really have to address this in any program that we are addressing. Next slide, please. I think when we look at the causes of stigma, first of all is the ignorance, and this is from our own experience. People don't understand. People think diseases are a curse from God, or it's a punishment, or it's an unwanted. I think this causes stigma. When there's inadequate knowledge of a substance, people tend to want to create their own. And this leads to misinformation, and that misinformation then leads to judgment, prejudicial. Somebody, it becomes a prejudiced, judges others from a wrong perspective, that possible immorality and so on. And this is what is happening in the community that we work with. They tend to look at diseases as an immorality rather than a test or a tribulation from God and so on. Next slide. Effects of COVID, sorry, COVID-19 has created a lot of fear. And this also is from the perspective of the government handling of the COVID situation in the country. Inexperienced in handling COVID, there was a lot of brutality in enforcing the laws. The last point, which I have addressed, there was concern about hospitals being overcrowded and being areas where people would get infection by going to the hospital. So there was also fear of the health services. There was a lot of fear, there was anxiety. When people saw the deaths, there was trauma amongst the society. And therefore, in addressing health, we had to look at the general perspective of health in terms of the COVID. There was a lot of concern in that area. And therefore, health was affected. People feared to even uptake the healthcare system. Inadequate consultation by the government to the community, I think this was very crucial. While the faith-based people were coming up with designs of how best to do this, it was also a challenge. Guidelines against Islamic religion, for example, the guidelines to prevent also affected the religion. For example, mosques were closed, prayer system, you are not supposed to be very close to each other, while in religion, you're supposed to be very close. This affected Muslims. Handling of the dead. Muslims have rituals, for example, and we know from experience that this also contributed to the increase in transmission of Ebola in West Africa and other places. So we came up with designs that were not very favorable to the Muslim community. So it affected the people, and we had to work, we had to do a lot of sensitization to get the cooperation of the people. Next slide, please. Fortunately, we have a lot of teachings in the religion that would help us. And this is what Islamic Relief Kenya is trying to do, to use the religious teachings to actually show the religious leaders that they have this capacity, they have this strength which they can use. For example, against stigma, the Quran says, "Oh, you believe, let not a group scoff at another group. It may be that the latter are better than the former." Whether it is a disease or whether it is a poverty or anything else. And then the Prophet ﷺ said, "The believer is not a defamer, nor does he curse others, nor is he an immoral talk. He does not talk indecently." So whatever we talk, whatever we say to the people, it is important that we use the scriptures to overcome the different types of stigma. Next, please. What are diseases? What are diseases? I think we understand that God loves us all, but God says that he will test us differently. And if we look at this verse, and certainly we will test you with something from fear, hunger, loss of wealth, lives, fruits or other harvests. There are 5 things. We see that from HIV and AIDS and also COVID, this verse fits very well because there is fear, there is loss of income, there is loss of lives, there is loss of harvest, there is hunger. People cannot gain food. But God says in the end, he says, "Give glad tidings to those who receive this, and they will receive his mercy, are those who are the guided ones, who persevere all this with dignity." So it is important to understand this perspective. And also that people think that they will just be left like that without being tested. So the principle of us being tested by God so that we can get closer to God is what the Islamic principle is showing that we should understand from these diseases. Next, please. We plan to, as a roadmap, in order to address these issues that have been raised, the issue of stigma in HIV. And as I indicated earlier, the consequences of stigma is actually that fear of health facilities, fear of whatever. It could even affect the gains that had already been achieved through HIV reduction of and suppression of the viral loads because of compliance to treatment and so on. That stigma could affect this. So as Islamic Relief, we plan to develop a working relationship with faith leaders to address gender-based violence. And there's so much of that in terms of females not being able to forced marriages, female circumcision, violence in the home, and so on. All this we plan as an activity and prevention of HIV and also improving uptake of healthcare services. We believe with the support, the Islamic Relief has already started this program as part of the roadmap. Next, please. These are the comments that we have made, and we hope that we shall be able to share this message, because it is important for people to understand that even the religious leaders themselves may not understand their capacity or may not understand to translate these scriptures into practical use into the lives of people. So this is what Islamic Relief is planning to do. And thank you very much for the organizers and giving us the opportunity to present these views. Thank you very much, Madam Chair.
Well, thank you, Professor Karama. I have to say that your presentation was extraordinary. I think we could combine your presentation and Father Rick's presentation and come up with a whole series of conversations around the theologies that and the way that we can use our theologies to respond to crises like the ones we're facing in HIV and COVID. So thank you so much for that. And so let's go ahead and cap off these last two sessions with the second half of Paul's incredible video.
Hospitality to strangers, including refugees and the displaced, is a gift that surpasses narrow and divisive definitions of religion. In the Bekaa Valley of Lebanon, these ordinary Lebanese women, Christian, Muslim, and Druze, work together to prepare food for refugees from war-wracked Syria. Religious groups who offer hospitality often find themselves transformed by the experience.
My name is Rolf Held. I am the local Methodist minister here in Meßstetten and in Albstadt-Ebingen, a town 10 kilometers from here. And I was a pastor in a rural church here, very quiet. We enjoyed doing the things one did in Germany, drinking a beer, watching football, celebrating services on Sunday, and caring for about our own thing. And then last year, we got the news that the army barracks here in Meßstetten, which had been empty for a year, were going to take in refugees. They promised us a maximum of 1,000 refugees in a town of approximately 6,000 inhabitants. Yes, so now we have just over 3,500 refugees in this small little town. And it's been a very interesting process to see how the population reacts to it. This is a very rural place, far away from the big cities. They've never seen much of the big wild world around them. And now it's dropped right in front of their doorstep. They've risen to the challenge. There's over 150 people doing voluntary work here, and the administration would never be able to cope without the people doing voluntary work. We're having interesting conversations with the refugees coming in. People are very different. We have mainly people from Syria, from Iraq, from Iran, Afghanistan, to a lesser degree from Eritrea in Africa. And we try to get to know the people, listen to their stories, find out how long it took them to get here, why they left home, what they experienced at home. Some of the experiences have been very harrowing and difficult to take in. And we found that we've met a lot of great people here. We have most of the people coming here are Muslims. We found they are very open. They come to our Christian services in our local Methodist church. A lot of them want to find out, what do Christians do? They come in. We do not try to convert each other. We try to speak with each other, share our faith, let each other know what we believe in and how we wish to live our faith. So we've been getting along very well. We've been finding that the refugees coming here are very, very helpful. We have a lady in our church. She has MS. She can hardly walk anymore. And she got befriended with some people from Iran. They washed her car. They painted her house. They fixed up her garden. They've packed up her cellar. They've come every day to see if they can help her. We've had this kind of helpfulness throughout the whole year. It's been an incredible experience how these people want to give back a little of what we try to convey to them.
When the refugee crisis in Europe began 6 years ago, and hundreds of thousands of refugees started flowing toward Western Europe, governments and NGOs were slow in responding. It was ordinary people, fishers, farmers, who responded to welcome the boats and save those drowning off islands in Greece. All around Europe, people organized themselves on social media to meet and welcome the migrants, even as their own governments at times rejected the newcomers. Such a massive outpouring of solidarity wasn't enough, however, and many refugees didn't make it. This Afghan boy had new shoes, and we can imagine the family buying them with the excitement of setting off to start a new life far from war. Yet during the crossing from Turkey to Greece, the Aegean took away one of those new shoes, just as it took away his dream of living somewhere, anywhere, in peace. Such grassroots solidarity is more necessary than ever. Immigrants have proved especially vulnerable to HIV, and more recently, people living in crowded camps or on the road have little ability to protect themselves from the coronavirus. At the same time, the climate crisis is driving more and more people to leave home, even though they aren't afforded protection by current international refugee law. Many people today are driven from their homes by violence, and given global imbalances of power, protest usually gets them nowhere. Cambodians displaced by giant development projects are repressed if they protest. Indigenous groups in the Philippines have their leaders assassinated and are forced out of their traditional villages by giant mining operations, forced to take refuge in church compounds. In Brazil, the rural poor have their forest homes destroyed by loggers. Native peoples in Argentina lose their land to giant fields where corporations grow soybeans for China. From one end of the earth to the other, people are forced to flee their homes in order to survive. When they resist, as these farmers resisted the theft of their land for a palm oil plantation in Honduras, they pay a heavy price. The number of refugees, displaced, and stateless people is growing, and so are the challenges they face. As people of many faith expressions, let's continue to unite to give voice to the voiceless, offering refuge and health to all who are forced to leave their homes. In the process, opening ourselves to be blessed in our encounter with the migrants in our midst.
Well, that video certainly proves, I think, what we all know, and that's a picture is worth 1,000 words. So, Paul, thank you for sharing that incredible piece of work. Very, very moving. So, thank you for that. And I think, Francesca, I think we're going to go to now to a couple of questions. We're running a couple of minutes behind, but I think it's really important to address some of the questions and comments that we're receiving. We may not get to them all. We'll find a way to address all of them, but maybe just not in the context of our event today. But there are, we have two questions for Alina. Julian, are you on the line still? Are you with us?
Yeah, I am. Hi.
Hi. Could you pose your question, please?
Okay. Thank you, Alina, for a very good, informative presentation you gave to us. Could you please suggest some ways in which FBOs could be of support to the work you do in the context you described? Thank you.
Thank you so much for that question, Julianne. And I should say that faith-based organizations are among PICUM's members. And a number of them are directly engaged in facilitating access to healthcare for undocumented people, precisely in settings where the national legislation is really restrictive. Working really at the local level, often partnering with local authorities to fill gaps in services. So I think for me, there's kind of two things maybe to mention. The first is, I think, to just pick up on what was just raised in the very powerful video about grassroots solidarity and trust building, which also came up earlier in an earlier panel. And I think faith-based organizations have an enormously important role in grassroots solidarity, in bringing understanding of these issues in a very humanized way and mobilizing around these issues with people who don't necessarily see how it's relevant to them, who don't understand how it touches them. And that can be through, and also, of course, mobilizing around support and care for migrants themselves. That is enormously impactful in contexts where there's otherwise no other option. But I think creating safe spaces for provision of care is really important, but also even safe spaces for people to have a voice. Here in Brussels, for example, there have been hundreds of people squatting in a church in central Brussels, really calling for the improvement in the situation of undocumented people. And this is a church that for 2 decades has been opening their doors to allow this type of grassroots mobilization, creating a safe space for people who otherwise could face arrest if they assemble in this way. And then just the second thing I wanted to mention is coming back to where I started my presentation, is just the role of faith-based organizations in changing the way we talk about migrants, which especially undocumented people, where there's already deeply dehumanizing language, even in the way we sometimes refer to undocumented people. And that language affects policymaking. And just changing the way we approach policymaking that concerns migrants in a way that really takes as its starting point, as I was saying earlier, values. Very often when we're speaking about undocumented people, that's not the starting point. It's more about deterrence. It's more about borders. And so I think that is changing, contributing to that change in narrative in the way we speak about people, the way that we think about and frame these issues is enormously important and impactful.
Thank you so much.
Thanks, Julianne, and thanks, Alina. Alina, I think we have one more question from you for Vincent. Vincent, are you there?
Yes, I'm here.
Go ahead, please.
The question is, we know that a disproportionate number of migrants who reach the UK for certain, and I suspect Europe also, are also people living with HIV. And I'm wondering, in what ways do the refugee agencies and programs integrate HIV and the welcome of people living with HIV into their program responses?
That's a great question, Vincent, and thank you very much for asking. Now, I don't have insight on how, I mean, as I mentioned earlier, the situation in Europe is very fragmented and differentiated from one country to the next. And so even whether, in the case of undocumented people, whether they even have a right to screening, testing, and care for HIV is actually a matter that varies from country to country. Now, I know of a number of national level organizations that work with migrants that do facilitate as best they can access to HIV related care. But I can't speak specifically for what is happening in the UK. But I just wanted to mention, and perhaps you're already aware, that the European Centre for Disease Control and Prevention actually has highlighted that a great concern is actually the number of migrants who actually contract HIV after coming to Europe. And this is a very, very significant concern and one that really deserves a lot of attention. So on the one hand, yes, people arriving, ensuring that they get treated the way that they ought to, if they're already HIV positive, but recognizing that that is happening on a greater scale than maybe was understood after arrival. And those people who remain in an irregular situation very often have very, very limited access to a healthcare system that could support identification of their illness and a continuity of care to ensure a good outcome.
Great. Thanks so much. And I think we have one more question before we move to the next session that's a little more generic to our panelist. Dyson, did you have a question?
Yes.
Okay, go ahead, please.
My question is, what would be the best practice the church can do in order to secure or to protect those immigrants, unprotected immigrants, or those who have no documents?
Thanks so much. Panelist, Father Rick, do you have comments?
I'm sorry, I couldn't hear the question.
I think Professor Karama wants to respond.
Oh, good. Okay, I couldn't see that. Okay, so Professor Karama, do you want to go ahead and let me just repeat the question? I think it's, so what can the faith community and churches do with undocumented immigrants? I mean, what are the sort of best practices and actions that our faith-based organizations can take in response? Professor, you want to go ahead, and then Rick, I'll come back to you.
Thank you, Madam Chair. I think this is the experience we have in Kenya also, that the border is so porous. People come in, they don't have documents, then they even travel to the urban areas and in search of health, seeking health, and so on. It is upon the local communities that identify these people and assist them to get government recognition. Otherwise, they will be continuously be harassed because of the security problems and whatever. So we encourage people to register as people who need help. You can imagine our borders surrounded by many areas with a lot of problems in Kenya. So people come from different directions, but we start maybe recognizing these people right from the point of entry into the local communities, and then this is notified to the 10 households. There's the process of 10 households where any new person coming in is recognized and possibly given supported and given the necessary direction to be registered. However, we also have criminals and other people with bad intentions who come in and they hide in the population and so on. But that's what we do, at least to ensure that migrant communities are taken care of. Thank you very much.
Thank you.
Madam Chair, I've not raised my hand, sorry. I'm missing that button, handshake, also for Sun Relief Worldwide. If you can just add on to what Professor has just said, for undocumented people and the people coming from the porous border, I think what the Kenya government has done to enable them also feel at home in terms of inclusivity is faith leaders sometimes be part of the vetting process. And they also participate in identifying these people together with the local authority to ensure that the expectations are met, they are dealt with in a very dignified manner. So normally they feel honored when a faith leader is part of the process in terms of ensuring that as much as, they may feel that they may be arrested or perhaps they may be harassed, but if the faith leaders are part of the committee set up by the local authority to ensure that these people get the services that they're supposed to be receiving when they're with the host community. We've seen that in the biggest refugee camp in Dadaab. Equally, we have another camp in Kakuma in Kenya. So for the ones who cannot perhaps have an opportunity to go to these camps, this process of localizing the process at every single village level, as Professor Mohammed has said, in terms of 10 houses, and then the faith leaders play a role in ensuring that these people are not, troubled, but they normally get the services required in a very dignified manner. Thank you.
Thank you, Jama. Father Rick, can you make a brief comment? Because I'm trying to get us back on track in time. Thanks.
Yeah, I just agree with everything people have said. And I think, we, all of us, Christian, Hindu, Muslim, need to use the pulpit. We need to use the pulpit better and preach karibu, 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 that the dignity and the welcome of people. And I think that's brilliant that some faith leaders are also on the committees that help screen. Great ideas.
Thanks so much, Father Rick. And I'm going to move us along and introduce Father Monsignor Bob Vitillo. We all call him Father Bob. So to lead us toward the way forward. Father Bob, are you there?
Yes, I am here, and Sandy, and I hope I'm Bob to you. So, and to everyone else who's on with us.
I don't want to be disrespectful when we have on the line. Thanks.
Actually, it's hard to do a summarizing of this, and I would going to suggest that we just keep on talking among ourselves, but I'll get into trouble with Francesca. So I will try my best to do a brief summary, but really so much has been said already, and there's so much reflection that I think all of us need to do after we finish this webinar as well. But maybe just to go a bit step by step, because I think it was also an excellent coordination so that many of the reflections then we had actual real life examples given to us, both by Paul Jeffrey, who always does such a great job with this, but also by each other. And, Carlos, I think you really started us out in such an important way to remind us that this is not something that's totally new, and that if anything, it's brought out the rupture in society, in economy, and in human relationships that has been there already. But this time, because it was so universal, the experience of this, we're seeing those ruptures and those fractures in humanity much more greatly. And I'll have to go back to my leader in Pope Francis, who's constantly telling us, make sure we're not thinking that we'll go back to the old normal when this is all over, because normal was not normal at all. So I think the whole issues that have been brought up around human behavior, personal perception, claims of human freedom to be able to do things that are not responsible toward other people or even to ourselves, politicization of the context, the closing of borders that may have helped arrival of the infection in some places, but they certainly didn't stop the infection. And then for us to remember, as you pointed out, Carlos, the lessons learned that we already had, especially with HIV, but with many other vulnerabilities that we have in this world. And the important lesson of if anyone is left behind, no one will move forward. The need for an integral human development approach. And certainly this is something that many nations have talked about through the Agenda 2030, but also in many faith leaders have talked about, and especially again, Pope Francis speaks about this very, very often in terms of the answer to many of these ruptures in human society is integral human development. I think also, Carlos, you're pointing out that these are overlapping crises of health, economy, protection, and then perception, that we can not only think about our own situation, but we have to think of others as well. Rick, it was beautiful to hear theology articulated, but then also encouraged and inspired in the way that you did. And especially the point about, the commonality that we have in the foundational values of so many of the major faith traditions and among so many people of faith. And the fact that we need to understand better our own dignity that we have because we were all created in the image of God, but also then the mission that God gives us. And yet contrasting that, as you did, Rick, with the fact that for many migrants, their sole experience is dehumanization, not affirming their humanity and the contribution that they bring. Pope Francis often talks about how integration of migrants isn't just a one-way direction. It's not just hosts welcoming migrants. It's a two-way relationship. And we need to remember that those who welcome also benefit from the values, from the hard work, from the determination, from the faith of many migrants that's been lost in secular society in many parts of the world. We need to give primary consideration to address basic needs, but we also have to eliminate the idea of us and they, or us and them. God reveals hope through ourselves to anyone experiencing rejection and alienation. And Rick, you made that very practical in talking about the 3 rules in EDARP of spend time with God, take care of yourselves, and take care of the patients, and never change that order. And of course, the African value of karibu, the behavior that we often, so many of us who visit or have lived in Africa experience that from the local communities. Rick, you also pointed out the contribution of art to these considerations, and you pointed out the beautiful sculpture of Angels Unaware, and the fact that that we are all migrants. We all came from migrant stock, and for the most part throughout the world. And it's when we forget those migrant roots and the discrimination that we may have faced or that our ancestors may have faced, that then we start to slip and reject others as they are arriving. You talk about, Rick, the theology can help us to understand healthcare systems, but we need to address every aspect of need and revealing God's loving care to all. Paul, you took all of the concepts and the beautiful words that Rick shared with us, as well as the actions he shared, and really made them real. You showed us how people are putting into practice what our beliefs are, and we need to continue to do that. And I was just thinking about, how much of what you showed, Paul, was a portrayal of the different stages of pilgrimage. People fleeing because of their threats to their own lives and dignity and families, but also then seeking asylum, trying to integrate, and in some cases, having other durable solutions like resettlement or return home when that's safe and that's voluntary. Pope Francis talked so much about the welcome, protect, promote, and integrate. And I really also appreciated, Paul, your focus on the migrant workers. So many times we focus only on refugees. They need that attention. We even have special international protection mechanism for the refugees. But many, many migrant workers have been forced to leave their home countries because of abject poverty or other compelling reasons. And they leave and they suffer and they sacrifice to support their families at home, and yet at the same time are serving others. And I think that needs our attention, especially in terms of what happened with many, many migrant groups, both international and domestic migrant groups, when the lockdowns came and they were left without any work and even without any possibility of returning home. Gary, you really helped us look at the roadmap again. I'm really pleased with that. I remember the discussions and the reflections and the debates that we had when we formulated that now, I guess, 2 years ago. I think, I really appreciated, Gary, you're talking about the need to combine the spiritual and the healthcare messaging. I would just open that up a little more to combine that also with the integral human development messaging that we need. And you recognize that it's not an easy path, Gary. You talked about a lack of data. I think it's not so much a lack of data as a real need to unveil that data. The faith groups have it, but often they don't take the time to document it very well. And then I just wanted to quickly, I know that we have a time problem, but I really appreciated, Alina, your talk about the disparities. I would open that up to inequalities, because I think it's easy for us to think of disparities as being something outside. But if we look at things as inequalities, it means that we're not treating people equally in the way we want to be treated. And then I really appreciate, Alina, your answer on the question and noting the fact that faith-based organizations and traditions really promote grassroots solidarity. And we saw that happen in many other pandemics, including HIV, Ebola, and others. But now we're seeing it all over again in the work that we have in response to COVID. And I wanted to note that I really was impressed on the COVID, how WHO and governments reached out to the faith communities and asked us to involve faith leaders to be able, especially to bring access to healthcare, but especially to combat the disinformation because of the credibility that many faith leaders have, and the fact that many times people go first to the faith communities for help. I'm getting signals. I believe it's probably from Francesca. I've gone too far, so I'll stop there, but thank you very much.
Thank you, Father Bob. That was wonderful, a great summary. Let me go to quickly to Dr. Vanderlot and to Gary to see if you have final comments for us.
Well, thank you very much. This is very, very challenging role also to be respondent at this time because of the great input and great presentations. So still, I think still much needs to be done. COVID has made health inequities evident, but also how far we are still from the real universal health coverage or universal health systems and migrant inclusive societies. So I think that also it's clear that faith-based organizations are there as first-line responders to COVID, to HIV, to health for the most vulnerable populations. And I think that faith-based organizations have the trust and the open dialogues with the communities. So their involvement is essential for an effective response to COVID and to HIV. I think that also we don't need to reinvent the water. We do have a roadmap which could make our coordination and joint actions more accessible and possible. So let's use it to move forward. And yes, the last message is basically that we need to adjust our narrative. Also, as Alina said, and also the narrative in terms of the public health perspective. I think that Father Rick said, not us and them, but only us. And I think that is basically the main way to go, in terms of looking at this as a society, not as at them and us, etc. And finally, the true biopsychosocial and spiritual model of assessment and care. So I think that, I don't know, it's just a lot of things that were said, great things, very relevant issues. And I really thank you all for being here. Over to Gary.
Gary?
Yeah, thanks very much. I've just seen the time, so I will be even briefer than what I was on the roadmap. But just thank you so much, everyone. That was an unbelievable session. My major takeaway is dignity, is that we need to dignify migrant health. It's a verb. We have to be proactive. We have to be innovative. We have to make sure that those rights are respected, that we have to create a sense of dignity. From that perspective, we can then start to build that trust, which faith-based organizations, which have been shown time and again, they enjoy a certain relationship with migrants, with vulnerable communities, impacted communities by all sorts of violence, disaster, and that we need to actually start working to show that we can have a real protected dignity when we work with those people. And Father Bob was absolutely right. The information is there, but we need to see it, and we need to generate that real values-based information. And as Alina pointed out, it's great that we start not with policy, but we talk about values. And I think, again, this is something very special that the faith-based community can bring. So generate, share from the pulpit, as Father Rick said, and let's get the message out there. Let's be proactive, and let's actively dignify this whole totality of healthcare for the migrant. I better stop there. Thank you very much.
Thanks so much, Gary. And thank you, Carlos and Father Bob, for your thoughtful interventions. I want to just end by thanking Jacek and Julianne at UNAIDS, and of course, our fearless Francesca, who always keeps us moving forward, for making this possible for all of us. And to all the presenters, thank you. And to our participants for your thoughtful interventions. And we will certainly look at the questions that were in that we didn't get a chance to address, and get back with you all on email. But again, just thank you for being with us, and we look forward to being with you all again. Take good care.
Big thank you to our great facilitator, to Sandy, to our interpreters, our IT team who made this possible, and to Jean-Charles, who is always with us as a good spirit and great technician. So colleagues, we leave the link open for 2 more minutes because we noted enormous interest and great exchange of opinions and comments in the chat. For colleagues who still keep their rates up, their hands up, please, you have 2 minutes to enter your question or comment in the chat box, and all this will be registered and will be recorded, and we will try to come back to you with answers in a follow-up webinars. Obviously, please do follow the Interfaith Health platform, where we will be announcing our next webinars. Big thanks to all. Stay safe, and bye-bye.
Bye. Take care, everyone.
Bye.
Bye-bye.
Bye-bye.
Bye.
Bye. Bye from Nigeria.
Bye from India.
It has been a good cause. Bye-bye.
He's not here.
Bye.
It's because we have to speak, please.
Bye, everyone. Bye.
Bye-bye.
Nice to meet you all. Keep in touch. Take care.
Bye, Jacek.
Bye, everyone. Bye, everyone.
Bye.
Bye from Nigeria. Bye from India. Bye from India.
From DRC.
Yeah, Nigeria say bye-bye.